Dr. Marco is turning later, is it?
8:40, already recorded.
Ah.
I think we should start. It's 1 minute past.
Vinay.
Good evening, friends. A very warm welcome to this physician's course in heart failure. This is the third such program that we are doing, supported by European Society of Cardiology Heart Failure Association. The object of these programs is to update our knowledge and of our physicians so that they can manage their patients better and provide them with quality medical care. The details of the program will be discussed by Dr. Harikrishnan. So I would urge you all to join in this program and follow the lectures, etc., to the best of your ability so that we can update our knowledge. And with that, let me hand over to Dr. Abraham Uman, the President of Heart Failure Association of India. Dr. Abraham.
Thank you, sir. And as we all know, Dr. Chopra is the original force behind this organization, which has grown in leaps and bounds with great effort. He was the first president, followed by Dr. Harikrishnan. And it's been a very academic organization. And we are very focused on academics. And heart failure is the burning problem now because heart attacks are increasing, but still the delay in presentation leads on to heart failure. So heart failure, even though we have a age-wise benefit for Indian population, these diseases, especially heart failure, is going to take away our demographic advantage. And the heart failure is not a pure domain of cardiologist or heart failure specialist. It has to go to the physicians and the primary and secondary care healthcare professionals. And with this, we have designed a beautiful a meeting for physicians. And as I mentioned before, this is the third one. And Dr. Harikrishnan has been the brain and the driving force behind each of these meetings in the last 3 years. And this is a full self-contained module and with help from the faculty from the ESC. So I urge everybody to go through it, learn, because if we cannot treat heart failure well, then we are going to harm the patient. So Dr. Hari will take you through the steps of this meeting and what we aim to achieve out of it. Over to Dr. Harikrishnan.
Good evening, everyone. Thanks to Dr. Chopra and Dr. Abraham Uman. We know that heart failure is an emerging health pandemic. The 5-year mortality of nearly 60%, as we reported in the Trivandrum Heart Failure Registry, is higher than many common cancers. The guideline-directed therapy is received only in around 25 to 40% of the people, indicating that there is a significant scope of quality improvement initiatives. We know that system inertia and physician inertia is the most important factor contributing to the low prescription rate of guideline-directed therapy. So one of the ways to improve is to have physician education programs where we discuss the evidence-based therapy and how to improve the prescription of guideline-directed therapy. We have planned a 6 weeks course starting from today, every 2 weeks till the end of December. The program is supported by Heart Failure Association of the European Society of Cardiology. Every day of the program, we will have one of the reputed international faculty from ESC Heart Failure. And the first day today, we are starting with a pre-test. So I will show the link to the, I think you must have received a link to the pre-test in your chat box. So you click on that and it will take you, or you can scan the QR code which is there on the screen. You can do this and you will be taken to the pre-test. The pre-test will be 25 questions. You can answer. At the end of that, you will see how many you have scored. So after you will be given a time of 25 minutes. And after 25 minutes, I will come with a PowerPoint showing all the answers and discuss for some 10 minutes. And then we will go into the 3 talks. Initially, the talk is on heart failure in the Indian context and some pathophysiology. Then Dr. Venugopal will discuss about the clinical evaluation of heart failure, which is a forgotten but very important tool. And finally, Dr. Marco Metra who is the current president of the Heart Failure Association of the ESC, the incoming president of the Heart Failure Association of the ESC, he will be speaking on the phenotypes of heart failure, which is a very important concept. So we will start first with the pre-test. So you can scan the QR code and directly go there, or the link is available in your chat box. So please go to the pre-test and answer the questions, and you can generate your score. Nobody else can see your score. It will be only seen by you. So you can evaluate yourself, and once you discuss the questions, we will know what are the real points behind the questions. So over to the pre-test. So we will come back at 7:30 with the first the answers to the pre-test, and then we'll go to the first talk. So over to the pre-test. So Vinay, will this now also will be live, or?
Yes, yes.
Okay.
So, good evening, sir. Manish this side. Sir, just
Yeah,
got it from the back.
I think we will discuss this. This is live. This is
Oh,
live.
I'm sorry.
Good evening, everyone. Welcome back. So we will go to the answers to the questions, and hope everybody could answer take the pre-test and answer the questions. Vinay, can you enable the screen sharing for me?
Yes.
So can you see my screen?
Yes, sir.
So we'll go through the questions one by one and we will answer. So what first question was, what was the commonest etiology of patients admitted with acute heart failure in India? The answer is ischemic heart disease. Both the Trivandrum Heart Failure Registry and the National Heart Failure Registry have shown that 70 to 75% of the patients in India presenting with heart failure is due to ischemic heart disease. The second commonest cause is dilated cardiomyopathy. The next question was on the 1 year mortality of patients with heart failure according to the Indian registry data. The Trivandrum registry showed it was 30%, and the National Heart Failure Registry, the unpublished data shows it is around 22%. So the average is around 25%. So 1/4 of the patients at least are dying at 1 year. Next is what percent of the patients in India who present with heart failure have preserved ejection fraction? That is ejection fraction more than 50. That was the question. The answer is 10 to 20%. So the data shows it is around 15 to 16% of those who have ejection fraction more than 50. But in the Western world, it is almost 50-50. Reduced ejection fraction and preserved ejection fraction is 50-50. But in India, it is only 10 to 20%. Next question is, a 45-year-old gentleman evaluated prior to hernia surgery was found to have LV systolic dysfunction, EF 45% on echocardiography. He is said to be in which stage of heart failure? The stages of heart failure has been defined by ACC/AHA and also by the universal definition. Stage A is anybody with the risk factors who is prone to develop heart failure. This patient has LV systolic dysfunction, which is already there is evidence of structural heart disease. So he is in stage B of heart failure. Stage B of heart failure. This is from the universal definition and also by ACC/AHA. The next question was the physical sign with the least specificity to diagnose heart failure in adults. The answer is bilateral pedal edema. Pedal edema, there are a lot of reasons to develop bilateral pedal edema, but positive hepatojugular reflex is a very specific sign. Cardiomegaly is a very specific sign, and the left ventricular third heart sound. These are very specific signs. So bilateral pedal edema is the least specific among the four. Next is, which of the following medications used for heart failure with reduced ejection fraction and do not reduce mortality? The answer is diuretics. All the others have shown to reduce mortality, but diuretics will produce symptomatic benefit, but it will not reduce mortality as such. But symptomatic benefit, diuretics is important, but other three groups of drugs definitely reduce mortality. Next question is, one of the following beta blockers are not recommended for treatment of congestive heart failure. This is metoprolol tartrate, that is a short-acting preparation, which you give 2 times a day. So you have to give the long-acting preparation, metoprolol succinate, in patients with heart failure. That is the only one which is recommended for heart failure, which have the evidence. So always give a long-acting metoprolol preparation for patients with heart failure. A 30-year-old patient comes to emergency with acute dyspnea. You order NT-proBNP. So what is the value for diagnosis of acute heart failure? So you should know the NT-proBNP value varies according to the situation. So these are the values of BNP and NT-proBNP. So acute heart failure, BNP cutoff is 100 and NT-proBNP is 300. Chronic heart failure, when the patient comes to OPD with minimal symptoms or something, it is BNP is more than 35 and NT-proBNP is more than 125. So the answer here is D, that is more than 300 picogram per hour. So which of the following has the least risk of causing hyponatremia? The answer is furosemide. So because the thiazide or thiazide-like diuretics can cause more hyponatremia than loop diuretics, even though loop diuretics is a more potent diuretic. That is very, very important. 7% of the hyponatremias among the total people with heart failure is produced by furosemide. The other majority of the more than 90% is produced by the thiazide diuretics. What level of dietary sodium restriction will you advise patients with symptomatic heart failure and features of volume overload? Its answer is 2 grams per day. That is 2 grams per day is 5 grams of sodium chloride or 5 grams salt. That is the answer. So another is a clinical problem. You have started a patient, ARNI in a patient with heart failure. Baseline creatinine was 1.5. It became 2 milligrams after 1 week. Urine output is normal. Serum potassium is normal. What is your plan of action? Either to withdraw ARNI, half the dose of ARNI, continue the same dose and monitor closely, change to an ARB. That is a question. The answer is continue the same dose and monitor very closely, because up to 50% increase in creatinine is expected in patients who are being started on an ARNI, and absolute value up to 3 milligrams per deciliter you can wait and closely monitor. Next question is the current role of digoxin in heart failure with reduced ejection fraction. Which of the following is true? It reduces mortality. It reduces rehospitalization. Benefits heart failure patients in sinus rhythm. 0.25 milligrams is the initial daily recommended dose by ESC guidelines. Only correct. The correct thing is reduce rehospitalization. It does not reduce mortality. It reduces only rehospitalization. It benefits patients in atrial fibrillation, not in sinus rhythm. And 0.25 milligram half daily, that is 0.125 milligrams, the initial daily recommended by the ESC guidelines. So another clinical situation, this patient is on metoprolol extended release 200 milligram OD. Arni 200 milligram BD, spironolactone 25 milligram OD, and dapagliflozin 10 milligram OD. The patient has a resting heart rate of 82 beats per minute. What will be your next choice of therapy? The choices are add digoxin, add ivabradine, add calcium channel blocker, change to carvedilol. The answer is the recommendation is to add ivabradine. If the heart rate is more than 70, when all the guideline directed therapy at the correct doses are given, especially beta blocker, you have to add ivabradine. That is the next step. All among the following physical findings used to assess fitness for discharge in a patient hospitalized decompensated heart failure, except normal, it is not physical findings, all the criteria for discharge. Sorry for the typo. Normal JVP, no dependent edema, no lung crepitations, and attainment of normal BNP levels. So the answer is attainment of normal BNP levels. So most of the times the BNP levels will not reach normal in patients with heart failure who are being treated. Other three conditions like normal JVP, no dependent edema, no lung crepitations are clinical criteria to discharge patients. And usually a value of 30% decrease in BNP values is possible. And BNP guided therapy is not found to be very useful. Next is, what is the 10-year survival of a post-cardiac transplant patient in established transplant programs? So this is the data from the West which we have available. It's a long-term outcomes, 10-year survival of post-cardiac transplant programs. It is around 60%. This is from the Australian data also. This is also from the US data also shows the same. So we don't have much drugs for heart failure with preserved ejection fraction, but recently some drugs have shown significant benefit with the composite endpoint of cardiovascular death and heart failure hospitalization, which is the drug which is found to be useful for preserved ejection fraction heart failure. That is, answer is SGLT2 inhibitors, dapagliflozin or empagliflozin in the EMBERR preserved or the DELIVER trials. A patient with heart failure, acute decompensated heart failure, presents with a blood pressure of less than 70 millimeters. What is inotrope of choice? The choice is norepinephrine. Norepinephrine is the inotrope choice when the patient presents with significant hypotension. Fluid restriction in heart failure, one of the following is not true. The thing is that a routine fluid restriction in my patients with mild or moderate symptoms without any evidence of congestion is not found to be beneficial. So patients who are walking about, who don't have any features of congestion, there is no role for fluid restriction. So it will be useful in patients with severe congestive symptoms who have features of volume overload, patients who are hyponatremia, and you can restrict to around 1.5 to 2 liters of fluids. Next is the target dose of ramipril in patients with heart failure with reduced ejection fraction. It is 10 milligram. So ramipril you have to try to reach 10 milligram or to the maximum tolerated dose, whatever you can achieve. That is a recommended dosage. So this is some points regarding therapy with ARNI. Which of the following is true? If the patient is on an ARB, should be stopped for 48 hours before starting on ARNI. A target dose is 200 milligram BD if tolerated. BNP should be the preferred biomarker than NT-proBNP. One advantage of ARNI is that it can be safely used in patients with hepatic impairment. The answer is B. All other points are wrong. The patient is on ACE inhibitor, you should be stopped for 48 hours, but the patient is on an ARB, you can directly start ARNI replacing it. BNP should be the preferred biomarker. Actually, NT-proBNP is the preferred biomarker because sacubitril degrades BNP, which leads to false elevation of values. And ARNI should be avoided in patients with significant hepatic impairment. So regarding natriuretic peptides, BNP and NT-proBNP, which is not true, it is more useful to rule out heart failure than rule in heart failure. That means that if you find a normal BNP value, it is very, very unlikely that the patient is having heart failure. But if you find a positive value or an elevated BNP levels, it may not be always heart failure. There may be other reasons also. We must use higher cutoff levels in patients with obese patients, but actually lower cutoff should be for obese patients. More than 75 years, the cutoff values is 1800 picogram per ml. That is also correct. Higher the age, higher the cutoff value. So you cannot use the 300 milligram, 300 picogram values for patients more than 75. And predicts outcomes in both preserved and reduced ejection fraction. It is correct. It can be used for predicting outcomes of both preserved and reduced ejection fraction. Drugs implicated in worsening of heart failure include all except you know that NSAIDs, silestazole, diltiazem, all can worsen heart failure. So the answer here is cilnidipine. The gold standard investigation for assessing the chamber volumes and ventricular ejection fraction is cardiac MRI. Cardiac MRI is the gold standard, even though echocardiography is the most commonly used investigation. The gold standard for volumes and ventricular ejection fraction is MRI. A 55-year-old patient, ejection fraction 35% on metoprolol, full guideline-directed therapy, metoprolol 200 milligram, RNA 200 BD, spironolactone 25. BP is okay, heart rate 68, left bundle branch block on EC, and had survived a recent cardiac arrest. So he requires a survived recent cardiac arrest. We had an arrhythmia, so he requires a defibrillator, and he has a broad QRS, left bundle branch block, 35% ejection fraction. So he is a candidate for a combination of CRT, that is cardiac resynchronization therapy, plus a defibrillator. So the patient is still symptomatic also, even on full guideline directed therapy. So patient should be on a CRT-D. Regarding readmissions in heart failure, which is not true. The answer is, I'm not going to those details due to the lack of time. So the wrong point is that 30% of the patients will get readmitted in 1 year as per Indian registry data. And all the 30% of all readmissions occur within the first week. That is because of the residual congestion. You are discharging them, the residual congestion. That is why they are getting back. And medication and dietary non-compliance account for 50% of the readmissions. And at the point I said, 25% of all patients discharged are still congested. That is the end of the questions. So thank you, everyone. And we will go to the next talk. So any comments from Dr. Chopra, Dr. Abraham, and we'll go to the...
No, I think these are extremely useful points. They are all of practical importance, and I hope Dr. Harikrishnan has clarified. He has clarified. I hope all of you have understood what he's trying to say. At the end of 6 weeks, we will again do a retest, and that is basically to assess how much has been the improvement in your understanding of heart failure. As Dr. Harikrishnan said, the marks are totally confidential. Only you know about it in this. But later on, once the certificate is given, you have to score a certain number before a certificate is given. Hari, over to you.
Yeah, so we'll go to the first talk. I have recorded the talk. Vinay, can you play that presentation? Good evening, ladies and gentlemen. Welcome to the Physicians course on heart failure by Heart Failure Association of India. I will present on heart failure in the Indian context and something about the pathophysiology, basic pathophysiology of heart failure. So why heart failure is important? That is the first thing we will discuss. We know that it is a disease with high mortality. As you can see in the graph, it is comparing the mortality of heart failure in men and women with the darker red shade, comparing to the mortality of common cancers like breast or colon or ovary. You can see that the mortality of heart failure is higher than the common cancers. As Arnold Katz has said, the central problem in heart failure is that patients can die. It is a mortal illness more serious than many malignancies. So it is a disease with high mortality. It has become a global pandemic. It affects around 26 million people worldwide, 2.2% prevalence in the US population. It accounts for only 2% of the total health expenditure, and more than 10% of the total health expenditure for cardiovascular disease in the USA is spent on heart failure. So socially, economically, and health system wise, it is very, very important. We know the therapy of heart failure is resource intensive. Reach to therapy is limited for majority of the population. We need a lifelong treatment. High mortality. 30% at 1 year, 60% at 5 years that I will discuss subsequently. The economic impact is high and there is significant loss of productivity. Now we will see what is the burden of heart failure in India. There is no real data on incidence or prevalence. If you extrapolate the US prevalence of 1.8%, it will come to around 14.4 million. So very large number of patients with heart failure. So what could be the current burden? What are the projections? So we know that as age advances, heart failure prevalence increases. So this is the prevalence of heart failure age-wise. You can see 20 to 39 to more than 80. You can see that at 80 years, the prevalence is around 12%. So India, we know the population is aging. This is the comparison of population in 2011 and 2051. You can see that 8.3% is going to increase to 21%. So naturally, as a population ages, heart failure burden increases. Risk factors for heart failure, we know India is a diabetic capital, 70 million in 2015 to 110 million in 2014. Hypertension prevalence, you must have read the meta-analysis recently, which showed a 30% prevalence among adults. And the sad part is that only 15% of them are controlled of the total hypertensives. Obesity is on the rise, and this is the age-adjusted prevalence of coronary artery disease. You can see that the more red the shade, higher the prevalence. You can see that the prevalence of coronary artery disease is equivalent to the Eastern European nations, where coronary artery disease prevalence is one of the highest in the world. And there is a rise in the prevalence. This is a study which we have done in Trivandrum after a gap of 23 years. You can see that 1993, when we assessed the population, the prevalence of probable coronary artery disease was 1.4. It increased to 3.5 in 2016. So there is a significant rise in coronary artery disease, which is one of the commonest cause of heart failure. If you go to the data on all diseases like rheumatic heart disease, still it is prevalent as you are coming across your practice. Congenital heart disease, we know that 200,000 children are born in India with congenital heart disease yearly, and late diagnosis and many of them going unnoticed, leading on to irreversible pulmonary hypertension. But the unfortunate part is that many of them have a repairable defect like a VSD, ASD, etc. Some etiologies are more common in the developing world, like India, like emerging infectious disease epidemic. For example, leptospirosis outbreak, it is said that 4% had complication of heart failure. This is the data from Trivandrum. Dengue fever, myocarditis, 13% had ejection fraction of less than 40. COVID-19, we know there are a significant number of patients who had myocardial damage and heart failure. Pulmonary hypertension due to various etiologies, for example, COPD, which is common due to the biomass fuel use, infective endocarditis, peripartum cardiomyopathy, anemia or iron deficiency, very common in this region. We can aggravate heart failure or precipitate heart failure. Rare cardiomyopathies like endomyocardial fibrosis in Kerala. So we know that heart failure is an emerging problem, and this is the data from the ICMR-funded National Heart Failure Registry, which we published in 2022. It's the largest registry which has a national representation. So the red stars are the nodal centers, like major centers like AIMS, PGI, etc. And there will be 5 centers around the nodal centers to have a nationally representative. We have almost all representation of all the ethnicities and the regions. So 200 patients from each center. So we collected the data of around 10,800 patients. What we found was the patients were younger by 10 years compared to the Western data. And males were more, 70% to 30%. In the Western world, it is 50-50 male-female ratio. And this is the age profile. Very interesting. You can see that this is the age profile from the Western data. You can see that 72, 73. China also, it is 72. Europe, 69. Our data, National Heart Failure is 59.9. So our patients, as I said, it is 10 years younger. Then what is the type of heart failure which is common? You can see that 2/3 of the patients in India have heart failure with a reduced ejection fraction. And only 12 to 16% of the patients had preserved ejection fraction, that is more than 50%. So 2/3 of our patients are having reduced ejection fraction. But you can compare the West, which is shown in green. You can see that a significant number, around 46% of the US population has heart failure with preserved ejection fraction. That is a major difference. So what are the etiology, the common reasons for patients developing heart failure? You can see that this is the data from the National Heart Failure Registry. 73% had ischemic heart disease, 17% had dilated cardiomyopathy, romantic heart disease account for around 6%, valvular non-RSD valvular heart disease around 2.3. So these three conditions, ischemic heart disease, dilated cardiomyopathy, and valvular heart disease, mostly romantic heart disease, contribute to around 95% of the burden of heart failure in India. So the most important condition is ischemic heart disease. So now we're coming to the guideline-directed therapy. Guideline-directed therapy is for the heart failure with reduced ejection fraction. So this study was done in 2019-20. So at that time, SGLT2 inhibitors were not part of the routine recommendation. So we considered guideline-directed therapy as a combination of ACE inhibitor, ARB or ARNI, plus beta blocker, plus mineralocorticoid receptor antagonist. What we found was 47% of the patients received guideline-directed therapy. Only 47% received guideline-directed therapy for all the three drugs. So, is there any benefit in giving the guideline-directed therapy? There is definitely yes. You can see that there is a significant benefit. You can see the difference in the p-value, p3 zeros. Heart failure with reduced ejection fraction. There is a significant benefit in patients receiving guideline-directed therapy in reducing mortality. Mid-range ejection fraction also, or mildly reduced ejection fraction, which is the patients with ejection fraction between 41 to 50%, they also derived a benefit. So what is the long-term mortality of these patients? The 1-year mortality is 30%, 3-year mortality is 45%, and 5-year mortality is 15%, and nearly 60% mortality. This is the data from the Trivandrum Heart Failure Registry, which we published serially. And now we are following up the cohort for 7 years. Our mortality is almost around 68% at 7 years. So, in general, heart failure in India, the burden is likely to be high. More in the younger population, mortality short and long term are high. Expected to rise in near future if the current trends continue. Because of the two reasons, a rise in the prevalence of risk factors and persistence of old age diseases. This is what we call as a double burden of heart failure. Now, the second part of the talk is about the pathophysiology of heart failure. I will not go into the too much details, but an overview of the pathophysiology of heart failure. So, before going to that, we should know the universal definition, because there were different definitions by different associations. So, there was a consensus in 2021 by the different associations. Heart Failure Association of India was also a part of that consensus statement. You can see that Heart Failure Association of India was also part of that. So what they defined heart failure is that heart failure is a clinical symptom with symptoms and or signs caused by a structural and or functional cardiac abnormality and corroborated by elevated natriuretic peptides, that is BNP or NT-proBNP, and or objective evidence of pulmonary or systemic condition. We will discuss in detail what it is. So they have classified heart failure into different categories based on ejection fraction derived by echocardiogram. So which is the most important screening modality. So reduced ejection fraction is less than 40%. That is called systolic heart failure. Then we have preserved ejection fraction when the heart failure is more than 50. Then there is another new category called heart failure with improved ejection fraction. Those patients who had an ejection fraction less than 40, but now their ejection fraction is more than 40. Either a 10% increase, a 10-point increase in the baseline LVEF, or the second measurement more than 40. So that is improved ejection fraction. So systolic and diastolic heart failure, we know, we have heard about that. Systolic heart failure is again the reduced ejection fraction heart failure when there's a systolic abnormality, there's a pumping dysfunction of the heart. So that is the cardiac output is low because of the reduced contractility or reduced pumping of the blood from the heart. Diastolic heart failure is a relaxation abnormality when the ventricle is too thick to relax. So then there is a heart failure with preserved ejection fraction. And there can be a combination of both, because systolic function patient also have some form of diastolic dysfunction. So we cannot strictly classify them into reduced and preserved ejection fraction as systolic and diastolic heart failure. There can be a combination in both. But in general, the management of heart failure to reduce ejection fraction and preserved ejection fraction are significantly different. So now coming to the pathophysiology of heart failure. So the cardiac mechanical dysfunction due to abnormalities can develop due to preload, abnormalities of preload, abnormalities of contractility, and abnormalities of afterload. So when there is increase in preload, the length of sarcomere is more than optimal and the strength of contraction comes down. When the preload decreases, the length of sarcomere, the myocardial sarcomere is well below the optimal, so the strength of contraction decreases. So the myocardial fiber has a maximum efficiency at 2.2 microns. If it is less than that or more than that, you can see that 2.2 microns is the optimal length of the sarcomere to generate the maximum benefit. Afterload, it is expressed as a tension which must be developed in the wall of the ventricles during systole to open the AV valves and eject the blood to the aorta or the pulmonary artery. So we know about the Laplace law, etc. I am not going to the details. So increased afterload, it may be due to elevation of the arterial resistance, which lead to increased ventricular size, all those components. I am not going to those details. Mechanical abnormalities can be due to the increased pressure load. For example, aortic stenosis, peripheral systemic hypertension, aortic coarctation, etc. that can lead to increased pressure load. Volume overload could be due to valvular regurgitation. Then obstruction to ventricular filling, like valvular stenosis, like mitral stenosis or pericardial restriction. Myocardial damage, it can be primary due to cardiomyopathies, myocarditis, or toxicity like alcohol cardiomyopathy, chemotherapeutic agent-related cardiomyopathy, metabolic abnormalities like hyper or hypothyroidism. Secondary to ischemic, that is the most commonest reason for myocardial damage. 73% of the patients had ischemic heart disease. Inflammation, chronic obstructive lung disease leading on to different issues, hypoxia, pressure overload, all leading on to myocardial damage. So what will happen is the essential physiological abnormality is reduced cardiac output. So what the body does is lead to compensatory mechanisms, which will try to restore the cardiac output. So what are the two systems which are activated? You must have read in your MBBS or MD days that autonomic nervous system or neurohumoral system, and the neurohumoral system will be activated. The first activation will be the autonomic nervous system. Like the sympathetic nervous system, which will increase the output, heart rate will increase, blood pressure will try to compensate, and fall in the parasympathetic nervous system. Subsequently, the neurohumoral system also will activate the renin-angiotensin system, the endothelin system, the natriuretic peptides, and cytokines all will get activated. So the adaptive mechanisms of the heart to the increased load will be using the Frank-Starling mechanism. We said about the sarcomere length, ventricular hypertrophy, increased mass of contractile elements leading to increased strength of contraction, increased sympathetic adrenergic activity, which will lead to increased heart rate and increased contractility, and activation of the renin-angiotensin aldosterone system. So this is a busy slide, but you can see that systolic heart failure or reduced ejection fraction heart failure, this reduced cardiac output activates the sympathetic nervous system, leading on to vasoconstriction, norepinephrine release leading on to cardiac remodeling. Again, the activation of the renin-angiotensin system, renin to angiotensin 1 to angiotensin 2, which release aldosterone, leading on to salt and water retention, angiotensin 2 leading on to cardiac remodeling like hypertrophy, apoptosis, oxidative stress, etc. Finally, sodium and water retention increase the cardiac filling pressure, try to compensate, but ultimately chronic elevation of the sympathetic activation and sodium and water retention will lead to congestion and the damage to the, and further augment the damage to the myocardium. Again, myocardial injury, decreased ventricular performance, decreased cardiac output, activation, body trying to correct, vasoconstriction, water retention, demand again on the heart, it aggravates the myocardial injury. This is a vicious circle. So where all these things act? So for example, the beta blocker therapy will act where there is chronic sympathetic activation, down regulation and decrease in the sensitivity, impaired inotropic and chronotropic responses leading on to worsening of heart failure. So that is where the beta blocker therapy acts and prevent the damages of chronic sympathetic activation. Again, the same thing, neurohumoral imbalance, vasoconstriction, which lead to increased blood pressure, increased sympathetic tone, again aldosterone increase leading on to sodium and water retention. This also will lead to myocardial fibrosis. So the last part I will say about ventricular remodeling. For example, the simplest thing to explain is a post-MI remodeling. For example, there's an acute myocardial infarction. You can see that the infarct zone will thin and elongate. And what will happen is the ventricle will dilate, and from an elliptical shape, it will go into a spherical shape, and the interstitial fibrosis occurs, and this will lead on to a myocardial ventricular aneurysm and lead on to ventricular dysfunction. So again, this is the areas where the particular drugs act. For example, beta blockers will act on the sympathetic nervous system. Vasodilators will act on where there is vasoconstriction. Beta blockers will act on again on the sympathetic activity, which will prevent the cardiac remodeling. Angiotensin receptors will act on the other areas of the renin-angiotensin system, and diuretics will control the sodium and water retention. So these are the different areas of action of the various drugs which are used in heart failure. So it will be discussed along with the particular areas when they cover those topics. So basically, to conclude, I can say that it is the basic pathology is reduction in cardiac output. Initially, it will be compensated by the compensatory mechanisms by activation of the sympathetic nervous system initially, and then the renin-angiotensin aldosterone system. But later, these compensatory mechanisms fail, and this is a vicious cycle leading on to further myocardial damage and clinical deterioration. Therapies, pharmacological, electrical, mechanical will be discussed in the subsequent days. Thank you so much for the patient listening, and you can post the questions in the chat box. Thank you so much.
Thank you, Dr. Harikrishnan, for a very detailed and lucid presentation about the pathophysiology, epidemiology as it applies to our country, and also telling us about the detailed mechanisms. Obviously, you can see that there are so many different etiologies, and all of them may follow different pathways to the end result of heart failure. Also, there are several phenotypes of heart failure, which Dr. Metra will be discussing today. And it's important to understand that the drugs which may act in one particular type of heart failure may not be really effective in the other type. So with that, let's open the discussion. Dr. Abraham Uman and Dr. Venugopal. Can you switch on your cameras, please?
No, it is not on.
Venus, your camera.
No, it's stopped by the heart. Okay.
Yeah, okay.
Yeah. Hari, an excellent presentation regarding the pathophysiology of heart failure and the points that you have elucidated.
We are going to your talk, or?
No. I think this is now session is now discussion on your talk, isn't it?
Yeah.
So as we learned from Dr. Harikrishnan's paper on Trivandrum heart failure registry, even when the mortality was very, very high, yet if you dissect out two groups, one group which received guideline-directed medical therapy and the other group which did not, there was a huge difference between the outcome, indicating that there's nothing in our phenotype which kind of portends a bad prognosis, but it is the poor application of guideline-directed medical therapy. Because in the same group, you could have two widely different results. That is a universal problem, not just in our country, but all over the world. But I must say that of late, I've seen the prescriptions gradually improving. New drugs which have come in, ARNI took a long time for people to accept because of various problems. SGLT2 inhibitors are probably easier. No electrolyte disturbances, no hypotension, single dose, no titration required. But then one has to be careful about genital infections and advise the patients accordingly. So
the prescription actually from the Trivandrum heart failure registry, which was done in 2013, and the National Heart Failure Registry done in 2019-20, there's a significant difference. Initially, the Trivandrum Heart Failure Registry was only 25% patient received the guideline-directed therapy, while in the National Heart Failure Registry in 2019-20, it became 47%. So there's a significant improvement over these years because of the awareness among the physicians and the data which is coming up, which is the robust data which is coming up. So there is an improvement. But worldwide, as Dr. Chopra has mentioned, and the guideline-directed therapy is not 100%. It is always in the tune of nearly around 50% or so. So there are many reasons like physician inertia, the fear about the side effects like hypotension, bradycardia, renal dysfunction, etc. So, where does sir?
Yeah, I think between the two drugs that are now coming into this thing, SGLT2 inhibitors have got a wider acceptance among the physicians. This is basically because one, I think probably the economic factor, which is very, very important. The other, the side effects which were highlighted with the RNA, which is many of them are unfounded, but there is a lot of fear to start RNA straight away. Even though we have now data about RNA, even it can be starting acute decompensated heart failure. So I think that is an area where more and more patients should be on this on RNA, the SGLT2 of the sacubitril valsartan drugs. Regarding SGLT2 inhibitors, the cost factor is very, very important. The cost has now come down, and you find that the SGLT2 inhibitors can be given in all types of heart failure, whether it's reduced ejection fraction or heart failure with preserved ejection fraction. That I think is a point in favor of SGLT2 being accepted more among the physicians. As Dr. Chopra said, genital infections need to be, I think the patient should be educated regarding the problems with SGLT2 inhibitors, especially personal hygiene, and also about how to monitor their how to monitor the use of these drugs. Abraham, is there any comment from Abraham?
No, I don't think he's
No,
around.
yes, sir.
So I think we can go on to the second talk because it's 8:10 already.
Yeah.
And Venu?
Yeah, I think my talk is already recorded.
Okay. So
Vinay,
when-
can you play?
Yeah.
Can you see my slides? Yes. Good evening.
We can see.
I would like to thank the Heart Failure Association of India for having given me this chance to talk on a very topic which is close to my heart. Clinical evaluation in heart failure, forgotten yet useful. Heart failure is a complex clinical syndrome resulting from structural and functional impairment of ventricular filling or rejection of blood. The term congestive is not preferred now since symptoms per se depend on right and left filling pressures. With better treatment of coronary artery disease, valvular heart disease, cardiomyopathy, and increase in longevity, heart failure incidence is proportionately increasing. Prevalence of heart failure is about 64 million people globally, and the prevalence is likely to increase by 46% from 2012 to 2030 as per the estimates. Nearly 8% of the population above the age of 65 are going to be affected. Females have relatively a less incidence of heart failure, but there is a higher prevalence in those aged more than 80 years due to increased life expectancy in the females. Early diagnosis of heart failure is essential for initiating guideline-based treatment and improving prognosis. Though investigations are playing a pivotal role in the management, a proper history and clinical examination are fundamental for the diagnosis, classifying into clinical subgroups, and proper management of patients with heart failure. If you look at the ACC-AHA stages of heart failure, we have stage A at risk for heart failure, people with hypertension, coronary artery disease, diabetes, obesity, exposure to cardiotoxic agents, genetic variant for cardiomyopathy, or family history of cardiomyopathy. In stage B, which is called as a pre-heart failure, the people without current or previous symptoms of heart failure, but have evidence of structural heart disease or evidence of increased filling pressures, like increased natriuretic peptides or persistently elevated cardiac troponin in the absence of competing diagnosis. Stage C is a symptomatic heart failure that we come across and treat in the hospital. Patients with current or previous symptoms and signs of heart failure. Stage D is advanced heart failure. Patients have marked heart failure symptoms that interfere with daily life and recurrent hospitalizations despite attempts to optimize guideline-directed medical therapy, and these are candidates for advanced mechanical support systems. If you look at the trajectory of class C heart failure patients, they can be new onset or de novo heart failure patients. They can have either a resolution of symptoms with improvement, or they can still continue to be in persistent left ventricular dysfunction, that is persistent heart failure. Some of these patients may not improve and continue to be worsening in heart failure. Look at the classification by the American College of Cardiology. The heart failure is classified according to the left ventricular ejection fraction. The heart failure with reduced ejection fraction, the criteria is left ventricular ejection fraction less than 40%. Heart failure with improved ejection fraction, previous left ventricular ejection fraction less than 40%, and a follow-up measurement of left ventricular ejection fraction more than 40%. Heart failure with mid-range mildly reduced ejection fraction, left ventricular ejection fraction is in the range of 41 to 49%. They may have evidence of spontaneous or provocable increased LV filling pressures like elevated natriuretic peptide, non-invasive or invasive hemodynamic measurements. The fourth group is a heart failure with preserved ejection fraction, which is now being more and more diagnosed, especially in the elderly population. They have a LV ejection fraction more than 50%, equal to or more than 50%, with evidence of spontaneous or provocable increased left ventricular filling pressures. Example, elevated natriuretic peptide and a non-invasive or invasive hemodynamic measurement. This is a European Society classification, the ESC classification 2021, which divided into three groups: heart failure with reduced ejection fraction, heart failure with mid-range ejection, mildly reduced ejection fraction, and heart failure with preserved ejection fraction. If you look at the bimodal distribution of heart failure with reduced ejection fraction is around 35%, and heart failure with preserved ejection fraction is around 55%, as we are now diagnosing more and more cases of heart failure with preserved ejection fraction. Now, the ACC-AHA classification of heart failure, as I've already mentioned, is compared with the NYHA functional classification. Stage A, who are at risk for heart failure, but without any structural disease or symptoms of heart failure, usually the NYHA classification is, they don't have any symptoms as per the NYHA classification. Class B, structural heart disease without signs or symptoms of heart failure, they may have class 1 NYHA. There is no limitation of physical activity, and ordinary physical activity does not elicit symptoms of heart failure. When you come to stage C, structural heart disease with prior or current symptoms of heart failure, they may have symptoms stages ranging from 1 to 3 in NYHA classification. In stage D, refractory heart failure requiring specialized interventions, usually these people are in class 4 of NYHA, unable to carry any physical activity without symptoms of heart failure or symptoms of heart failure at rest. The Framingham diagnostic criteria for heart failure was commonly used earlier. This criteria requires the presence of two major criteria or one major and two minor criteria to make the diagnosis of heart failure. The diagnostic tool is highly sensitive for the diagnosis of heart failure, but has relatively low specificity. It is divided into the major and minor criteria. The major criteria are acute pulmonary edema, cardiomegaly, hepatojugular reflex, jugular neck vein distension, paroxysmal nocturnal dyspnea, orthopnea, pulmonary rales, third heart sound S3 gallop, weight loss of 4.5 kg or more in 5 days in response to treatment, central venous pressure greater than 16 centimeter of water, radiographic cardiac enlargement, and the minor criteria are ankle edema, dyspnea on exertion, hepatomegaly, nocturnal cough, pleural effusions, especially on the right side, tachycardia, heart rate more than 120 beats per minute, a decrease in vital capacity by 1/3 the maximum value recorded. The clinical diagnosis of heart failure is actually based on history, physical examination, laboratory data, and imaging, though now we depend more and more on the laboratory data and imaging. The clinical gold standard is increase in pulmonary capillary wedge pressure at rest or exercise. Clinical examination can approximately assess the status of patients into 4 clinical groups: the warm dry, the warm wet, cold dry, and cold wet. Those patients who are wet have evidence of congestion with an estimated pulmonary capillary wedge pressure more than 22 millimeters of mercury. Those patients who are said as dry have inadequate perfusion, which is manifested by a cardiac index of less than 2.1 liter per minute per meter square. These are the 4 stages which I've already mentioned. In warm and dry stage, there is no evidence of low perfusion or evidence of congestion. Whereas in warm and wet stage, the perfusion is normal, but patient has evidence of congestion like orthopnea, elevated jugular venous pressure, pulmonary rales, and S3 gallop, and edema. In cool and dry, patients have evidence of low perfusion, but there is no evidence of congestion. The 4th group, which is a shock situation, patient will be having evidence of low perfusion at rest. At the same time, they will also have evidence of congestion. This is commonly encountered in cardiogenic shock situations. The risk factors for heart failure is ischemic heart disease, valvular heart disease, myocarditis, arrhythmias, diabetes mellitus, structural heart disease related to congenital heart disease, obstructive sleep apnea, obesity, alcohol and drug abuse, NSAIDs, and cancer chemotherapy. This is again as per the ACC, cancer chemotherapy and cardiotoxic medications, autoimmune diseases, endocrine diseases like thyroid, acromegaly, pheochromocytoma, diabetes, and obesity, familial cardiomyopathy or inherited or genetic heart disease, tachycardia mediated or PVCs or RV pacing related. That is what is called as tachycardiomyopathy, hypertension, infiltrative cardiac disease, myocarditis, peripartum cardiomyopathy, stress cardiomyopathy, substance abuse. Very often there are certain points that we overlook in the history. That is the use of cardio-oncology drugs, NSAIDs, genetic causes, cardiomyopathies, especially alcohol, arrhythmias, and pregnancy. The symptoms of fluid accumulation, as I said earlier, is dyspnea, orthopnea, edema, abdominal distension, paroxysmal nocturnal dyspnea. Symptoms of reduced cardiac output are fatigue and weakness. Clinical evaluation involves assessing whether the cardiac filling pressures are elevated, whether there is ventricular enlargement, both right ventricular as well as left ventricular, evidence of pulmonary hypertension, and to look for reduction in cardiac output. If you look at the symptoms associated with heart failure, fatigue, shortness of breath, dyspnea, tachypnea, cough, diminished exercise capacity, orthopnea, paroxysmal nocturnal dyspnea, nocturia, weight gain or weight loss, edema of the extremity scrotum or elsewhere, increasing abdominal girth or bloating, abdominal pain, especially right upper quadrant pain due to a congested liver, loss of appetite or early satiety, change stocks breathing, especially reported by the family than by the patient, diminished mental acuity. The cardinal sign of heart failure could be worsening dyspnea and fatigue. One of the most reliable signs are paroxysmal nocturnal dyspnea. And Cheyne-Stokes respiration has been noted to have adverse prognosis in patients with heart failure. And unintended weight loss is also a major prognostic indicator. Physical examination. The physical findings of heart failure are tachycardia, extra beats or irregular rhythm, narrow pulse pressure or thready pulse, pulses alternance, tachypnea, cold and mottled extremities, elevated jugular venous pressure, dullness and diminished pressure of the lung bases because of pleural effusion, Rayleigh Ronchi and Vesus, cardiomegaly as evidenced by apical impulse displaced leftward or inferiorly, sustained apical impulse, parasternal lift suggestive of right ventricular hypertrophy, S3 and S4 either palpable or audible, tricuspid or mitral regurgitant murmur, hepatomegaly, ascites, presacral edema, anasarca, pedal edema, and chronic venous stasis changes. Narrow pulse pressure or thready pulse, pulses alternance, anasarca are all indicative of, and cool and mottled extremities are all indicative of more severe disease. Orthopnea, JVP plus hepatojugular reflex are sensitive signs of heart failure, while RALS and JVP plus ascites are more specific. We have to remember there is no sensitive and no highly sensitive or specific sign for heart failure. These are the common clinical findings that we normally come across, that is cardiac enlargement, pulses alternance, scallop rhythm, raised JVP, resting tachycardia, narrow pulse pressure, sweating, and peripheral vasoconstriction. The wet stage in heart failure, which indicates elevated filling pressures, are raised jugular venous pulse or pressure, hepatojugular reflux, orthopnea, bendopnea, and square wave response of blood pressure during Valsalva. When you look at volume depletion, the signs are not as easily detectable as in congestion. The volume depletion signs are presence of orthostatic hypotension, tachycardia, narrow pulse pressure, proportional pulse pressure, that is pulse pressure divided by systolic pressure, cool extremities. One of the most important clinical signs of congestion is jugular venous distension and elevated JVP. Estimated JVP is more than 10 centimeters of water. It estimates the right atrial pressure. And the ESCAPE trial and the SALT trial both demonstrated elevated JVP and S3, either or both, were associated with an increased development of heart failure and composite endpoint of death in stage 2 patients with heart failure. Stage B of heart failure. Kussmaul sign, which is an increase in the mean JVP, has also been associated with adverse prognosis in patients with heart failure. In the absence of isolated right ventricular dysfunction, jugular venous distension is elevated with pulmonary capillary wedge pressure. Bendopnea is another important clinical sign that we elicit in patients with heart failure. Bendopnea means dyspnea occurring on bending forward at the waist. Patient is asked to sit on a chair and bend forward to touch the feet with one's hand. Bendopnea is present if dyspnea occurred within 30 seconds of bending. Bendopnea has been commonly found in heart failure. History of bendopnea is common in heart failure clinics, those undergoing cardiopulmonary testing, and those with acute decompensated heart failure. Bendopnea is a prognostic utility because it has been found to denote increased 6 months mortality in various trials. There is increased risk of death, heart failure admission, inotropic initiation, LVADs or transplantation in patients who had this symptom. But the problem with bendopnea is that it may occur in other conditions also, especially in marked obesity and in conditions like bronchopulmonary aspergillosis. Hepatojugular reflex is an increase in the JVP more than 3 centimeters sustained on 10 seconds of continuous pressure on the abdomen with abrupt fall after pressure is released. In a normal person, the moment the pressure is released, there is an abrupt fall. Hepatojugular reflex indicates a pulmonary capillary wedge pressure more than 15 millimeters HD in the absence of isolated systolic dysfunction. In patients who have positive hepatojugular reflex, the increase in JVP is sustained even after the pressure is released. Patients on persistent hepatojugular release versus resolved hepatojugular reflex in patients, those admitted with acute heart failure had higher risk of 6 months mortality. Orthopnea is a very common symptom in heart failure, and it is associated with elevated pulmonary capillary wedge pressure, where various measures of pulmonary capillary wedge pressures have been shown in the ESCAPE study, ranging from 28 millimeters, 30 millimeters, and 32 millimeters. It has been positively associated with jugular venous distension if there is no primary right ventricular pathology. Both are associated with the pulmonary capillary, presence of both are associated with the pulmonary capillary wedge pressure more than 30 millimeters of mercury. Combining both, an orthoedema score has been proposed, and it's a composite score, and an increased orthoedema score is associated with increased morbidity and mortality. Valsalva's maneuver, the blood pressure response to Valsalva's maneuver allows estimation of pulmonary capillary wedge pressure. Normally, during Valsalva's maneuver, once the strain phase, the initial phase, there is a fall in blood pressure. In patients with heart failure, there is a square wave pattern. The BP rises with strain, but does not fall and remains elevated throughout the strain phase. And this response has been correlated with invasive pulmonary capillary wedge pressure. Square wave response will not be present if there is isolated rise in RV end diastolic pressure due to isolated right ventricular pathology. You look at the sensitivity and specificity of history and physical examination for diagnosis and elevated filling pressures in heart failure. You find that those findings which have high sensitivity have relatively low specificity. For example, rails more than 1/3 of lung fields have a sensitivity which is only about 15. The specificity is 60. The specificity is about 69. Sensitivity is more. The other signs also, orthopnea, hepatojugular reflex, all are having sensitivity, but specificity is not as one would like to have. Clinical assessment of hemodynamics in patients with heart failure, as I mentioned, clinical examination of patients with symptomatic heart failure, you have to assess for congestion and assess for low cardiac index. Assessment of congestion is depending upon the presence of the following findings: right-sided elevated JVP or jugular venous distension, bilateral leg edema and ascites, left-sided congestion, positive hepatojugular reflex, orthopnea, bendopnea, and Valsalva square wave response. Assessment of low cardiac index, patients can be having either cold or warm presentation. Cold patients with cold presentation have cold lower extremities and narrow pulse pressure. Low cardiac index with warm extremities, if there is inadequate response to diuresis, one has to consider low cardiac index even though the extremities are warm. 70 to 75% of patients with right-sided congestion will have elevated pulmonary capillary wedge pressure, which has been mentioned already earlier, especially with those with jugular venous distension. If creatinine rises with diuretics and JVP is persistently elevated, consider elevated right atrial pressure, pulmonary capillary wedge pressure ratio. If you look at the ACC recommendation, in patients with symptomatic heart failure, clinical factors including the presence of advanced heart failure should be sought via history and physical examination. In patients with heart failure, a thorough history and physical examination should direct diagnostic strategies to uncover specific causes that may warrant disease-specific management. In patients presenting with heart failure, a thorough history and physical examination should be obtained and performed to identify cardiac and non-cardiac disorders, lifestyle and behavioral factors, and social determinants of health that might cause or accelerate the development of or progression of heart failure. If you suspect that the patient has got possible heart failure, the most important factor is a history and thorough physical examination. If it is an acute onset, non-acute onset, then you go for the investigations like ECG, chest X-ray, routine labs, and natriuretic peptides. If they are negative, heart failure is unlikely. If there is a higher suspicion, you have to go for imaging, abnormal. If the imaging turns out to be abnormal, then heart failure is likely. In summary, history and physical examination are fundamental in the initial assessment and management of patients with heart failure. Depending upon the clinical findings, patients can be identified as belonging to the 4 hemodynamic groups: warm, dry, warm, wet, cold, dry, and cold, wet. History and signs of like orthopnea, bendopnea, valsalva-osmia, hepatojugular reflex, which are not usually done, add additional information regarding management and prognosis of patients with heart failure. Signs of low perfusion status are less sensitive compared to signs of congestion. Imaging and biochemical parameters are complementary and do not supplant a meticulous history and thorough physical examination. Thank you.
Thank you, Dr. Venugopal, for a very detailed presentation about clinical examination of a heart failure patient. It's very important that with the availability of so many investigations and other modalities that help us diagnose heart failure, one should not forget clinical examination and a good history. Sadly, these are things which are often missing nowadays. Heart failure still remains a clinical diagnosis, and the other things are supportive, and they help us deal with the kind of heart failure a little bit better. So, shall we go on to the next talk? It's 8:35 already.
Yeah, I think we should go. I think one announcement. Some people couldn't complete the pre-test, and some of them joined later. So the pre-test will be available after this presentation. You can go to the pre-test. That window will be open, and you can answer the pre-test. And it will be available throughout the course, so that anybody who joins in between can take the pre-test. And please post your questions in the chat box so that we can answer the questions. I think people should know that there is an option to ask questions. You post your questions in the chat box, which will be answered. Thank you.
Good morning, good afternoon. Thank you very much to Professor Hare-Krishna and Professor Chopra for their excellent initiative that gives us the possibility to stay closer as much as possible. So my topic regards heart failure phenotypes, and I will evaluate them considering also the treatment options that we have in different situations. These are my disclosures, and this is the phenotypic classification of heart failure that we had in the 2021 ESC guidelines. And you see that we have actually the 4 pillars of treatment of heart failure with reduced ejection fraction that were actually based on the evidence from clinical trials. And then we had different treatments based on comorbidities and severity of heart failure. However, I will mainly concentrate on the classification of heart failure, the ejection fraction based classification of heart failure, and how this can influence our treatment. Because this is the major new evidence that we have had in the last years. were actually based on the evidence from clinical trials. And then we had different treatments based on comorbidities and severity of heart failure. However, I will mainly concentrate on the classification of heart failure, the ejection fraction based classification of heart failure, and how this can influence our treatment. Because this is the major new evidence that we have had in the last years. So what we had in 2021 is still an armamentarium of treatments that were just for the patients with heart failure and reduced ejection fraction. And the reason why this occurred is because all the trials that had given favorable results were based on the enrollment of patients with a low ejection fraction, below 35 or 40%. Instead, the trials that enrolled patients with ejection fraction above 40% gave neutral results. And actually, there were also epidemiological and clinical trials data to support the role of the ejection fraction. And this is a meta-analysis published more than 10 years ago nowadays. And this shows nicely that there is an inverse relationship between ejection fraction and mortality when ejection fraction is reduced, whereas when it is above 40-45%, mortality was somehow independent from the ejection fraction. More recently, we have had this other meta-analysis including more than 30,000 patients from clinical trials. It's important to point this out. And what was found, again, is a similar relationship, although without a clear threshold. There is a continuous line, and the line is J-shaped, so that we have an increase in the risk of death and pump failure death or sudden death or cardiovascular death and heart failure hospitalizations, but not non-cardiovascular death, when the ejection fraction starts to be below values like 50-60%. And then again, the risk increases at lower values of ejection fraction. This is what we have from clinical trials, and this is a basis for clinical trials. However, things are maybe a little bit more complicated, but if we stay with the guidelines, we have the subdivision of the patients in 3 categories: reduced ejection fraction, mid-range ejection fraction, mildly reduced ejection fraction, and preserved ejection fraction. Or we may have, like in the Australian, New Zealand guidelines, a dichotomization of the patients in patients with reduced and a normal or preserved ejection fraction. However, there remains the problem of what is normal. Normal may be above 50, 55, 60%, depending on the studies. And again, there is a gray zone where the ejection fraction is mildly reduced, but not severely reduced. Then to further complicate things, there may be this new category of patients that are those with supranormal ejection fraction, above 65-70%. The major basis for this classification comes from epidemiological data with echocardiography, collected in UK, and they showed a new shape relationship between ejection fraction and mortality. Of course, this was more evident in the younger patients and in females than in males. But in any case, there is an increase in the risk of death above 65-70% of ejection fraction. Further data show that these patients may be more likely to have genetic abnormalities, and when detected, they identify a subgroup of patients who are at risk particularly high. These are data from Japan, and again, you see that this increase in the risk in the patients with an ejection fraction above 75% is confirmed, and it is confirmed in female rather than in male patients. This is a study with hemodynamics that actually shows that the problem is not only the ejection fraction, but also, and actually even more, the left ventricular end diastolic volume. These patients with a supranormal ejection fraction actually have smaller left ventricular end diastolic volumes, and you see them also here in brown, so that at the same left ventricular end diastolic pressure, you have a lower left ventricular end diastolic volume in these patients. And this also is consistent with the fact that the stroke volume in the end may be normal in these patients. And so the term of chamber contracture was given to identify these patients. And this was also taken in an editorial comment by Milton Packard that actually identified these patients with a contracture of the left ventricle and the left atrium, and they are mainly women and commonly hypertensive, and they may not respond to neurohormonal antagonists. Then another category of patients may be that of the patients with improved ejection fraction. They are generally defined as patients who start with a low ejection fraction and have an increase, generally above 10 units of the ejection fraction, so that in the end it is mildly reduced or normal, above 50%. Nevertheless, these patients are at high risk, and they, if neurohormonal antagonists and or diuretics are withdrawn, they have an increase in the events and a worsening of symptoms. This is the time course of the ejection fraction in a large cohort of patients in Spain, Catalonia, and you see that there is an initial improvement in the ejection fraction, then it is stabilized, but then may go down again. The improvement is more likely to occur in patients with a normal coronary artery disease with idiopathic dilated cardiomyopathy. These are data from Sweden by Gianluigi Savarese, again showing that the ejection fraction is a dynamic measurement, and therefore it may decrease in a certain proportion of patients. And on the other hand, it may increase in other patients who start with a low ejection fraction and then go into the category of mildly reduced or normal ejection fraction. So this is the classification taken also in the universal definition of heart failure. Why is the ejection fraction important? The ejection fraction is important because what we have is a treatment just for the patients with a reduced ejection fraction, as already said, with the four pillars of treatment, the three neurohormonal antagonists plus loop diuretics, and then ICD and or CRTD when indicated. What can we do in the patients with mildly reduced ejection fraction? Post-hoc analysis have shown that also beta blockers, MRA, and sacubitril/valsartan and ACE inhibitors may be effective also in these patients. And therefore, there is room for their administration with a class 2B recommendation in the guidelines. What to say regarding sacubitril/valsartan, because it's the drug that was mostly studied to the largest extent in this category of patients before the gliflozins. Paragon HF was a trial neutral with respect to the primary outcome, but it showed an efficacy of the drug in the patients with lower than median ejection fraction. And then we have had Paraglide HF targeting patients hospitalized with heart failure and preserved ejection fraction, and showing a tendency to lower NT-proBNP plasma levels with sacubitril/valsartan versus valsartan, a tendency to an improvement in the win ratio, which was a main secondary endpoint, and again an heterogeneity based on the ejection fraction values at baseline. This heterogeneity is such that if we combine Paraglide HF and Paragon, we came to you can come to a reduction in the primary endpoint in the patients who had worsening heart failure, but also P0027 in the patients, in all the patients enrolled in these two trials. What's important is, again, however, the pooled analysis of the data and the subgroup analysis showing that the reduction in the events with Paraglide and Paragon HF with sacubitril/valsartan was significant in the subgroup of patients with an ejection fraction below 60%, but was not significant anymore in the patients who had an ejection fraction above 60%. So we may state that sacubitril/valsartan is effective in the patients with ejection fraction below 60%, but not, based on the data, in the patients with an ejection fraction above 60%, therefore normal or supranormal. What else? What else is that the problem of FPF remains, and these actually are the majority of the patients having access to an emergency department in our hospitals because of the increased prevalence of hypertension, obesity, diabetes, metabolic syndrome, whereas the rate of post-MI heart failure has decreased thanks to the primary angioplasty and to prevention measurements. And in 2021, we had very, very few recommendations for treatment in the patients with preserved ejection fraction, just diuretics and prevention. But a few hours later than the presentation of the 2021 guidelines, we had the presentation of the DAPA. We have the presentation of Emperor Preserved, showing the benefits of empagliflozin versus placebo in the patients with preserved ejection fraction. And the year after, we had the presentation of the liver with similar results with dapagliflozin versus placebo. The results in both cases were mainly driven by a reduction in heart failure hospitalizations, however. There was an improvement in quality of life with these two treatments versus placebo, and this is even more important as it is in a double-blind study. And there was, I like to present this slide, there was a better tolerability to other drugs that are potential candidates for treatment of HFpEF, namely MRAs. Here you see that in Emperor Preserved, the rate of hyperkalemia was reduced with compared with placebo by empagliflozin. And this is a meta-analysis of the 5 trials done in patients with heart failure with SGLT2 inhibitors, SGT inhibitors, and showing, the important part is here, that the likelihood to develop mild or severe hyperkalemia was lower with the gliflozins compared with placebo. And so actually, as the other treatment is likely optimized, we may consider that the addition of spironolactone or mineralocorticoid antagonists, whichever they will be, may be better tolerated with concomitant treatment with SGLT2 inhibitors. These are the ESC recommendation for the treatment of FMREF, mildly reduced. You see DAPA and empagliflozins have a class 1 recommendation. And these are the recommendations for the treatment of the patients with preserved ejection fraction. Then we have to remember that we have a condition possible of worsening heart failure, as summarized in this consensus paper from HFA. And worsening heart failure is when the patient is hospitalized for heart failure, but also when the patient undergoes an outpatient visit with intravenous diuretic treatment, or even with just an escalation of the oral dose of intravenous diuretics, of the oral dose of the diuretics. But apart from this, we have that whether the episode is intensification of treatment, emergency department visit, or an heart failure hospitalization, in all these cases, there has been an increase in the risk of events. What can we do more in the patient who has had recent worsening heart failure? We have another drug, vericiguat, which acts as a soluble guanylate cyclase activator and has decreased by 10% rehospitalization rates in the Victoria trial. Also, this drug has very mild effects on blood pressure and has been tested also with a very low glomerular filtration rate and showing its tolerability and its peculiar mechanism of action. So it has a class 2B recommendation in the new guidelines for the patients with an ejection fraction below 50%. Then we have other possibilities for the patients with heart failure, consisting in the addition of ferric carboxymaltose IV for the patients who have iron deficiency, and finding that we recommend to scrutinize systematically in the patients with heart failure, and because up to 50% may have a significant iron deficiency. And you see strong HF that had these very favorable results compared with placebo, with drug titration and frequent follow-up visits of the patients. Here you see the results. So this is the new recommendation in the guidelines 2023 to have frequent follow-up visits. Then what else? We have also treatment for prevention. And here the phenotype of interest is represented by the patient with diabetic cardiomyopathy, with diabetic nephropathy. As in these patients, again, SGLT2 inhibitors may reduce the risk of heart failure hospitalization and cardiovascular death. So there is this recommendation. In these patients with a diabetic nephropathy, also finerenone has favorable effects, as shown in the Fidelity pooled analysis. And as I already said, ferric carboxymaltose may reduce rehospitalizations in the patients who have iron deficiency. It also improves quality of life, and both these are recommended. Class 1A for symptoms alleviation and improvement in quality of life. Class 2A level of evidence A, because of Affirm HF and Ironman, and more recently also ART-FID, that showed a consistent reduction in the primary outcome of cardiovascular hospitalization or death, or heart failure hospitalization or cardiovascular death. Phenotypes are also important, and I try to summarize in patients with FPF. There has been machine learning, and there are specific phenotypes like the patients with chronotropic incompetence, in whom beta blockers may worsen exercise capacity. Hypertension is an important cause and comorbidity of FPF, and we have treatment of hypertension indicated. And we have also coronary artery disease, and we have also the possibility in 20% of the patients of pulmonary vascular disease and right ventricular dysfunction. These patients have a reduced vasodilatory reserve during exercise, have an increased risk of events, and we don't have a specific treatment yet. Then there is the obesity phenotype. We see that obesity is linked specifically with the incidence of FPF, and what we can say is that abdominal obesity is associated with an increased risk of events. There was no evidence-based treatment for patients with FPF until the last years. And we had exercise training and caloric restriction, which were effective in the patients with obesity and FPF. And more recently, we have had the results with semaglutide, a GLP-1 receptor agonist, and these are my last slides, that in a placebo-controlled trial in less than 500 patients has shown an improvement in quality of life by 7.8 points, with a concomitant decrease in the body weight. and a concomitant decrease in C-reactive protein, consistent with an anti-inflammatory effect and an improvement in many secondary endpoints. The effects was independent from body weight, and this is my last slide. There was a direct correlation between the decrease in body weight and the improvement in quality of life and exercise capacity, although body weight decrease is not the only mechanism of action of this drug. And I thank you for your attention.
Thank you, Dr. Metra, for that wonderful talk. So over to Dr. Chopra and Dr. Abraham for your comments and discussion.
Thanks, Marco, for joining in. And seems that you are at a reception, probably. But I found a couple of things very interesting. One was you mentioned that the mortality actually increases in supernormal heart failure with preserved ejection fraction. That was one. And second, I think Dr. Metra made a very valid point that even patients with guideline-directed medical therapy, once they improve their ejection fraction, in course of time, it starts going down. So that kind of, tells our colleagues that even if ejection fraction has improved, one should not take the foot off the pedal and continue with all the guideline-directed medical therapy and not stop it just because ejection fraction has reached the so-called normal range. Dr. Metra?
Dr. Metra, you are muted.
Okay, can you hear me now? Sorry for where I am, but I had a degree thesis a few minutes ago. Yes, with respect to the supernormal ejection fraction, probably it's an heterogeneous group. You have patients with hypertrophic cardiomyopathy, for example, and it's important to think that they may have a poor prognosis and that the ejection fraction may be too high, because in the next years we likely will have drugs specific for hypertrophic cardiomyopathy and to decrease contractility, like myosin inhibitors, mevacantem, and so on, and others, and so these patients may be treated. And the other important aspect, you can come, but close the door. The other important aspect regarding the time course of the ejection fraction, this is also another important story, and we must continue to think that these patients are patients. So even if the ejection fraction has improved, this may be transient, and above all, these patients still need drug therapy. This is also has been my experience also with some patients that wished to withdraw drugs, and then they had a decline in ejection fraction again. So it's very important that the therapy is maintained.
Yeah, the TRUD-HF study also showed that 45% of the patients who had stopped the drugs had a recurrence and heart failure and had to be restarted. So very important to continue even if the so-called echo-derived ejection fractions have become normalized. We may have abnormalities in strain imaging or in subtle forms of LV function assessment.
Yes.
There is a question in the chat box. Choice of SGLT2, among the two, do you have any particular choice or any?
No, I mean, what we say is that it's a class effect for the two that have been shown to be effective, DAPA or empagliflozin. You may look at the results of the trial, prefer one over the other, but yes, I don't think there are major differences that you may just, you say, use this or use this other one. Are they, do they cost the same in India? Yes, more or less, probably.
Yeah, more or less.
Yeah, so I don't think so. Sotagliflozin surely will be a different story if available. and because it takes also on the receptors, SGLT1 receptors that are located in the gut, so may cause diarrhea, but surely patients lose more sodium than with an SGLT2 inhibitor, and it may have, although the trials were underpowered, it may have also an effect on ischemic events. So this will be different, but for example, in Italy, it's not available for everyday use. Yeah.
So regarding the phenotypes in preserved ejection fraction, is there any consensus yet, or it is still in the making?
So phenotypes for the preserved ejection fraction.
Yeah.
Yes, this I mean actually was uncertain how to to do my talk, because there are also the phenotypes that are determined by comorbidities in reduced ejection fraction. I think that obese patients will be will have a different phenotype. Obese patients, surely obesity plays a major role in their symptoms and cardiac dysfunction. And we are facing a new era with these GLP-1 receptor agonists, because for the first time we have drugs that are safe and that can decrease body weight, and it's a matter of fact that the lifestyle interventions are very difficult many times to do in patients. Of course, I always recommend to my patient a nutrition specialist, physical activity, but also the brain is set to a certain body weight, and it's difficult to change this body weight. These drugs seem to act in this way. There are shortcomings, however, they may have gastrointestinal side effects. And the other thing is that when they are stopped, the patients gain the initial body weight. And so it may also be a problem for the healthcare cost of these drugs. But when new drugs will come out, there will be competition, and they will decrease somehow their price, I hope.
Dr. Abraham, any?
Yeah, Professor Mehta, thank you for a wonderful talk.
Thank you.
Few questions for the physicians, like 6-minute walk test, where do you place? Global longitudinal strain, where do you place? And see, these are simple, but and a very common question asked nowadays, because a person gets hyperkalemia. So can we replace eplerenone or spironolactone with finerenone now, especially in a person who had
Abraham, you're getting muted.
1 or 2 episodes of hyperkalemia? Can you hear me?
Yeah, I can hear you. Yes, pretty well. So you asked the 6-minute walking test. I'm not a fan of the 6-minute walking test. Above all, there are patients with heart failure are frequently elderly with comorbidities. So it's difficult, maybe difficult. On the other hand, if we have to decide for heart transplantation, cardiopulmonary exercise testing may be better standardized. There are some diseases like primary pulmonary hypertension, where repetition of the 6-minute walking test is mandatory in the guidelines, and surely has to be done. Well, it can be used. It depends on how you deal with the patient. They are tools that, having time, surely help you to follow the patient. Also, having questionnaires for the quality of life, like the KCCQ, they could be also administered in everyday clinical practice and may help to evaluate how the patient feels. and I hope that SHFA will be able to develop an even simpler method to assess quality of life. GLS, global longitudinal strain, surely it's impaired earlier than ejection fraction. And in some cases, for example, in cardio-oncology, I see it's very useful, at least to detect early an impairment of left ventricular function. Then again, the importance in clinical practice is still not settled yet. I mean, there are no trials that enroll patients based on GLS. Then you asked for finerenone.
Finerenone.
Yeah, finerenone, I think it's a big hope. First of all, it's associated with less hyperkalemia than the steroidal aldosterone antagonists, and at least on kidney function, it has a protective effect that has not been shown, at least in heart failure patients with the traditional aldosterone antagonists. Of course, there will be a problem of the cost of the drug, and probably, I mean, and in FPF, it may be that finerenone is positive, but maybe that also spironolactone is positive in the SPIRIT trials. So the cost will become a variable to consider. I'm not, there is no doubt, but on the other hand, the finerenone, the data are favorable now.
So one question in the chat box, when a patient develops UTI with SGLT2 inhibitor, what is your plan of management? Will you stop it completely, or will you retry, or what is your status?
Urinary tract infection.
Yeah.
I try to resist. I mean, it's like the hypotension for ARNI and maybe better. So urinary tract infections are not a contraindication to SGLT2 inhibitors. You treat it, you give antibiotics, and above all, in practice, it's a major problem to advise the patient for genital tract hygiene measurements, and sometimes I have patients who have problems like that can be surgically treated, and I call the urologist and say, okay, it's not a cancer, but it may be life-saving even to have this treatment of phimosis or a problem like this. So, I mean, I try as much as possible to treat these infections and at least not stop the SGLT2 at the first episode.
Okay.
But
okay, thank you. So, Dr. Venugopal, any comments? Muted. You are muted.
okay.
This is a very excellent talk. And
Thank
very
you.
happy.
Thank you very much. Okay.
So I think it is 9:15 and we have to wind up. Thank you, Dr. Metra, for joining us and giving us the wonderful talk. I think thank you, ESC Heart Failure Association, for joining us in this very important initiative in improving the heart failure care in India. I think we look forward in all the remaining 5 sessions. And we had a pre-test, and there are people who are waiting to get the test because some people joined later. So this course, this pre-test will be open throughout the course, and people can, all the videos will be recorded, will be available in the website. You can, if you have missed some of the talks, you can always go through that again. And hope you will be useful. And you can post the questions here. I think some of the other questions are there. We will try to answer these questions in the next first 15 minutes of the next day. We will answer these questions. So please post your questions either today or you can send by email in the address provided. So we'll try to answer those questions. So thank you everyone. Thank you, Dr. Metra. Thank you, Heart Failure Association of the ESC. And thank you, Vinay and the team, and Eris Pharma, who is supporting the program with a with the unconditional educational grant. So thank you, Eris and the team, and thanks everyone who has joined. Thank you. Good night.
Right.
Good night.